Hi, everyone, and welcome to the third event in our Hurricanes and Health session hosted by the CAFE Climate and Health Research Coordinating Center. I'm Rachel Nethery. I am a CAFE team member and an associate professor of biostatistics at the Harvard School of Public Health, and I'll be moderating this session, which is going to be Emerging Research Lightning Talks. And so we have, I believe, 8 fantastic speakers that are going to do short talks, about 6 to 7 minutes each. And immediately after each speaker's talk, we'll be able to ask them maybe one question just to keep things moving. We're going to keep the Q&A very short here. So feel free to, while the speakers are speaking, if you have a question, put it in the Q&A, and I will try to prioritize the questions and ask them verbally at the end of each speaker's talk. So our first speaker is Dr. Arnab Ghosh, and I am going to hand it over to you, Dr. Ghosh, to take it away.
Yeah, thank you. Hi, everyone. My name is Arnab Ghosh. I'm an assistant professor of medicine at Weill Cornell, and I've focused on hurricanes and particularly the long-term effects. So I'm going to get started. Can you please move ahead with this next slide? So my experience with hurricanes comes from both being a researcher and practitioner, as someone who's cared for patients and victims of hurricanes in the aftermath. What you can see here is a picture of Hurricane Maria, which is my first experience in the United States, actually, looking after post-hurricane victims. If you move to the next slide, please. And so I was positioned, I was deployed to Manatee after the Hurricane Maria hit in October 2017. Next slide, please. And here we were able to see through direct care some of the consequences in the aftermath of these disasters, which we published in this paper in Pre-Hospital and Disaster Medicine. So we looked after patients, individuals, about 2 or 3 months after the event. And what you can see here is a distribution of the ages of the people who are still experiencing healthcare needs at this point in time, 2 to 3 months after the event. You can see here that there's 2 real peaks. There's a pediatric population under the age of about 10, and then there's this other population approximately with a peak around the age of 50. And so when you look at what was bringing these people into hospital in the aftermath, in the short to sort of medium term after the event, next slide, please. Yeah, next slide. Well, what you can see here, and this was very rudimentarily done because we were looking after patients at the same time, these individuals at the same time as trying to characterize their illness. So it doesn't follow your classic ICD-10 or 9 categorization. You can see that even after the event, infection risk was predominantly the biggest concern, particularly in the pediatric population, but also extending to the adult population. But what you can also see is that the management of chronic conditions was more pronounced at this point in time, particularly as you got older. And this reflects the fact that as you get older, the propensity for chronic illnesses increases and chronic disease management increases. Moving ahead, please. So what we went ahead and did is we started examining, I had a particular interest in cardiovascular health because I looked after patients who had heart attacks, who had strokes, and had really heart failure exacerbations after the event to evaluate more concretely what the evidence suggests. And what we found was that in the studies that looked at particularly cardiovascular disease, which is a pretty common illness in the United States, there wasn't really rigorous long-term effects that have been studied. There weren't focuses on EJ communities, and that multiple exposures weren't really a consideration. And so there's a little limited understanding of the long-term mechanisms that were really driving a pretty common problem, which is the risk of heart attacks, strokes, and heart failure. Next slide, please. So what we started thinking about is how do you start studying this and how do you analyze this? And when you start thinking about the longer term implications of how disasters and particularly hurricanes affect individuals, we had to think about this. I argue that we had to think about this a little bit more ecologically because the data generating processes that lead to the propensity to have increased risk are multitudinal, and they include social factors, economic factors. And so we actually wanted to look at this in one case, and we looked at that in Hurricane Sandy, using an ecological model and looking at Medicare beneficiaries because they're the easiest population to study in the longer term. Next slide, please. So what we did to start off, and this is a paper in Press, we started looking at that data generating process, particularly for older adults. And we had to think about place-based attachment. We had to think about aging in place issues. And so what we did is we tried to assemble some characteristics of the cohort that was at risk after flooding from Hurricane Sandy, based according to the existing literature, and how these factors played a role within each other. Next slide, please. And so, thank you. So what we did, we started analyzing, again, at an ecological scale. In this case, it was zip code level, because that's the smallest spatial unit we could look at for Medicare beneficiaries, where flooding was in relation to where people lived. And so what we were able to see, if you go to the next slide, please, and this is particularly this is one case in Hurricane Sandy affecting New Jersey. If you start looking at the risk of CVD events in the aftermath across multiple different regions, you can see here what's categorized in purple, multiple different significant values, which sort of speak to the fact that it's about 6% or 7% increased risk of overall CVD that appears to be driven by heart failure events in the aftermath, and actually a lot more by New Jersey rather than the other parts of the country, of the regions that were affected. And next slide, please. So what we also did was some event study plots to look at how long this risk accelerated for. And if you look at CVD risks in the aftermath, where if you look at that line down at point 10, which represents the quarter that Hurricane Sandy hit, you can see there's an acute blip about quarter 13, 12, 13, which is the acute events that take place after the hurricane. But then you see these persist, sometimes significantly, sometimes not. But upwards of 26 or 27 quarters after, which represents roughly, I can't do that math in my head, 2 or 3 years after the event. And so this would suggest that there are long-term impacts of these these hurricane events that I think need to be explored and understood as hurricanes become more frequent. I think that's it. Oh, sorry. And the last slide, why is this important? We wanted to understand this because we felt that existing public health programs are designed to ameliorate risk, either in the preparedness or the response phase, could actually be improved by examining the long-term implications, particularly as hurricanes become more frequent, intense, and geographically diverse. And so the Empower program is one program that we've been actively thinking about employing the long-term impacts into risk assessment of those particularly vulnerable people from not just hurricanes, but actually a multitude of disasters. So I think that is truly it. Yeah, thank you very much. Happy to take a question.
Thanks, Dr. Ghosh. Fantastic presentation and really cool research. So I have a question. And it's the same as the one that was asked in the chat, basically. So, I think Elaine put it better than I would have. She says, how do we account for the possibility of multiple exposures when looking at long-term outcomes? And I would say in my own research, we've tried to deal with the issue of this and found that if you're thinking about the health impacts as long-term, then considering that in many places that are prone to hurricanes, they get hit with hurricanes, once every year or 2 years, a lot of times. It's almost like if you're thinking about that health impacts might last multiple years and they're getting hit by hurricanes every year, how do you find any sort of baseline time at which you can evaluate that you can use to kind of actually evaluate the health impacts of storms? So I'm curious if you have any thoughts on any of those things. They're difficult questions, I think.
Yeah, no, that they are. And I think this speaks to, if you start using causal inference methods to understand the links, it becomes incredibly hard, because I think that this idea of a natural experiment and the underlying structure of how society functions in the aftermath of events fundamentally changes. And so this idea that you're looking at a before and after period and you're trying to do that rigorously is incredibly hard. We did it with Hurricane Sandy, making the argument, and we looked at the pre-trends of event study plots, and they looked like they weren't significant. But if you can, I'm not sure if we can go back, but you can see that, that Hurricane Irene hit the year before Hurricane Sandy hit and actually impacted Jersey more. And so that could be one explanation for why you see these events increase in that particular region. And if you look at the event study plot, it's indexed on the quarter before Hurricane Sandy hit, but you can see that there's actually a dip at the same time the Hurricane Irene hit. Now, it didn't affect pre-event trends when we statistically evaluated, but I think that probably explains it. This will become incredibly hard as we move forward. And I think that we may have to come up with new methods ultimately. We'll think about time varying characteristics that can account for this. But the data right now, it doesn't allow us to do that.
Yeah, agreed. Thanks so much, Dr. Ghosh. So we will move now to Jiang He, and please go ahead and take it away.
Hi, I suppose you guys can hear me, right? Okay.
Yep.
So good afternoon, everyone. My name is Jia Hang, and I'm a second-year PhD student at Boston University. And today I will share an early-stage project on mine, showing with some simple visualization, showing some new evidence of compound effects of tropical cyclone and extreme heat to mortality in the US. I will discuss heat and tropical cyclones separately. So for heat, many works have already shown that U-shaped curve for mortality. So deaths are high when temperature is low, then decrease until around 20 to 25 degrees, and rises quickly once daily mean temperature strays far from 25 degrees. Showing that cold and hot tails are both harmful, and heat does more harm. So on the next slide, on tropical cyclone side, we usually see that death rate keeps roughly the same before the wind speed of tropical storm, which is 34 knots or 70.5 meters per second on wind speed. So Parks et al. Documents sharp spikes in cardiorespiratory deaths right after TC landfall, and other studies see excess deaths even below hurricane force. Yang and Xiang, in their 2024 Nature paper, trace elevated mortality for over a decade, around 14 years, and deaths peaked at around 5 to 6 years after a tropical cyclone event. So both heat and storms are lethal on their own. The open question is, what happens when they strike together? Well, some research have considered that. They mostly use climate models to simulate and project future possible deaths instead of tracing back. So tracing back is what I want to explore a little bit more on another level. So next slide, please. To discuss this question, we want to know whether tropical cyclone and heat compounding hazard is a common thing or not. So I use county level CDD24 data. So CDD24 is degree days above 24 degrees Celsius in a month. I find that some storm months reach values of 220. In Florida, Texas, and many other hurricane-prone states, typical CDD24 during cyclone season is on average above 90. These numbers confirm that heat storm overlapping is pretty common and could be dangerous. So on the next slide, I use mortality data from CDC Wonder, meteorological variable from ERA5, and tropical cyclone tracks from NOAA IB tracks with wind radar reconstructed by the Xu et al. 2024 algorithm using random forest. And these data I use are all on county months level from 2000 to 2022. Altogether, that yields 389 storms and 145 storm months touching a little bit more than 2,000 counties across 35 states in the lower 48 states of the US. So next slide, please. So first, I do a simple estimation on county and months fixed effects level using linear model, and the outcome is death rate with county and time dummies soaking up the confounders. So on the left panel of the plot shows raw wind speed. Right panel of the plot recenters wind at 34 knots. So the value on the right hand side of the plot read as extra wind above tropical storm force. Across different thresholds, months, and big seasons like 2005, 2017, 2018 subdata, we can see that blue is nearly always above orange, and most confidence interval clear zero. So the gap quantifies gases attributable to heat acting with wind, not wind alone. Recentering at 31 knots shrink levels, but the pattern survives. So then on the next line, I re-estimate using a Poisson pseudo maximum likelihood panel with the same phase defense. I'm sorry. Could you do one slide? Yeah. And so we can see the magnitudes drop as expected because I'm using DESCONT, log DESCONT at the outcome. But we can take the ranking holds. Blue consistently exceeds orange. So these Poisson results reassure us the finding isn't driven by linear model assumption or outliers. Next slide, please. So let's ground these coefficients using Hurricane Irma as an example. Plugging these values on the slide into the model gives us a 2.04 decis per 100,000 population for standalone wind effects. But when we include the interaction with heat, the estimation jumps to 2.87, which indicates the death rate increases around 40%. With 2.7 million population in this county, Miami-Dade County in 2005, it means that more than 80 additional deaths in that month could be attributed to high temperature and tropical cyclone compound hazard. Next slide, please. And another question I want to ask is whether this heat wind compound effect would last longer than a month. When I lag the model 1 month and keep the CD24 index, heat completely dominates while the wind effects vanish. In other words, the short run compound punch is real, but short-lived in this temperature matrix. This is kind of expected because heat does not persist, especially on a monthly level. 1 month after could be cooler compared to the months hurricane hits. So on the next slide, I replace CDD24 with CDD18, which captures milder but longer lasting heat. I still find a small yet significant hurricane heat interaction 1 month out. That might suggest lingering health burdens, perhaps through disrupted infrastructure, power outages, or limited access to cooling. Moreover, a non-zero lag wind term hints at extended vulnerability among at-risk population right after tropical cyclone hits a region. So I don't really have a summary page. These are the references I use. But to sum up, extreme heat and tropical cyclone will interact to amplify mortality beyond their separate effects. Future work of my project will explore heterogeneous effects by age, income, and race in regions with different vulnerabilities, urban, rural areas, and test whether adaptation like wilder air conditioning access can blur the compound hazard. Thank you for listening, and I welcome your questions.
Thank you so much. This is really fascinating stuff. I just had one quick question. So would it be possible to look at effects on a sort of shorter time scale than a month? I could imagine that that heat in particular tends to act on a very short time scale. And so do you think it would be possible to see, to investigate effects in like the immediate days or week after a hurricane rather than looking at the whole month?
This is a really good question, first of all. The biggest limitation of doing that in a more granular or finer scale is data. So we don't really have data, like especially mortality data on daily level or weekly level, because public accessible data for mortality usually suppress a large value of data points for a lot of reasons. So CDC suppresses a lot of data points for various reasons, and if we do that on a finer scale, there will be more suppressed data, which does not make the analysis possible, or there will be, you can think of running a regression and drop about 60 to 70% of data points that doesn't really indicate a lot of meaningful things.
Got it. Yeah, data limitations. That makes sense. Thank you so much. Great talk. Very interesting work. Looking forward to hearing more about that. I will now hand it over to our next speaker, Elizabeth Fussell. Please feel free to introduce yourself and take it away. Is Elizabeth here? Okay. Bear with us for just a quick second then. Okay, great. So our speaker after Elizabeth is Shuizhuan Ning. Are you ready to go? Oh, yep, I see you.
Yep.
Take it.
Sure.
Oh.
Yeah.
Sorry.
It's okay. Yep.
Perfect.
Hi, everyone. I'm Shuizhuan Ning, a PhD candidate in environmental health sciences at Yale School of Public Health. My talk is on tropical cyclone exposures and adverse birth outcomes in Georgia State. Next slide, please. I don't need to belabor this more. Tropical cyclone and its hazards, which could include high sustained wind speed, extensive precipitation, and storm surge, and flooding, and etc., may affect perinatal health through direct and indirect pathways, as illustrated in the plot. Next, please. And there's a growing body of literature on this topic already, but findings are inconclusive with some birth outcomes. And proposed design is often used in this area of research, which might not fully control for some temporal and spatial confounding. And a lot of studies focus on a single storm, which might be difficult to generalize the findings to other storm events. And wind speed is the most commonly used metric to measure tropical cyclone exposure. However, there are other features of tropical cyclones that are important to consider as well. And lastly, majority studies focus in urban areas, leaving rural areas understudied. Next slide, please. So our objective are to evaluate tropical cyclones' impact on different birth outcomes and to investigate urban-rural health disparities. Next, please. We chose Georgia as our study region because Georgia State is located on the East Coast, affected by Atlantic Basin tropical cyclones, and Georgia is less studied because of infrequent direct landfall. However, many storm tracks do cross Georgia inland, causing extreme precipitation and flooding, etc. In your sample, we included 1.4 million live singleton births in Georgia from 2000 to 2018. We excluded births with missing data or not during hurricane seasons. And finally, we have a total of 55 tropical cyclones that passed by Georgia during the study period. Next, please. And for birth outcomes, we're interested in preterm births, low birth weights, small for gestational age, and male infant sex. And the analysis we use are binary variables, so they're preterm births or not. And we aggregated the outcomes at weekly and county levels just because of the very low count of these rare outcomes sometimes. And next slide, please. For exposure metrics, we quantified exposure using 4 distinct metrics of tropocyclones, including max sustained wind speed, cumulative rainfall, distance to the storm track, which is a proxy variable for exposure, and the tropocyclone-related flooding events. Since there are no concerns on the cutoffs of these metrics, we explored a couple of different thresholds based on data distribution, and the data sources are from the R package hurricane exposure and exposure data by Dr. Anderson's team, and some rainfall data from NLDS2 analysis product. Next, please. For urban rural indicator, we use the USDA's RUCA primary codes to examine the health disparities because it captures both populational density and community patterns, which are important during disaster disruptions. We divided the code into metropolitan areas and more rural areas. Next, please. And for analysis, we use the 2-stage time series approach. In the first stage, we ran county-level zero-inflated Poisson regression models to account for the excess zeros in the outcomes and adjusting for temperature, seasonality, long-term trend. And we also use weekly total births as the offset to estimate the relative risk of adverse outcomes. And in the second stage, we conducted a pooled analysis of the county-specific relative risks using random effect univariate meta-analysis, both overall and by rural urban. And we also conducted a series of sensitivity analysis to test robustness of our findings, but we won't be going into the details today. Next slide, please. And this is our main findings. So you can see from this bar plot of relative risks, peak wind speed and cumulative rainfall and distance to track were associated with high risk of preterm births, low birth weight, and small for gestational age, with some sort of dose-response relationship where higher exposure cutoffs were associated with higher risk of these outcomes. And flooding was associated with mostly growth restriction outcomes, including low birth weight and small for gestational age, not overall for preterm births. And we didn't find any association with male birth rate. Next, please. And when we stratify by urban and rural indicators, we can see across the board the magnitude of risk was generally greater in more rural areas, marked by the teal bars, with a red star marking the significance of the findings, particularly for distance to track and some rainfall outcomes, and for flooding events for preterm births. So in rural areas, flooding events are associated with higher risk of preterm births. This suggests that rural areas do have disproportionate risk than urban areas, perhaps due to difference in healthcare access and resources. Next slide, please. And in summary, we show that multiple county-level tropocyclone metrics were associated with risk of preterm births, low birth weight, and small for gestational age, and the effect size tend to increase with increasing storm intensity. And the effect is more pronounced in more rural areas. No association was found for male birth rate. And overall, we found that even less intense storms may be associated with adverse birth outcomes. Next slide, please. I'd like to thank my collaborators and acknowledging the NIH funding supporting this work. Next slide, please. And these are the list of reference I use. And next slide, I'm happy to take a question.
Thank you so much. A really interesting talk. I haven't seen research on birth outcomes and tropical storms before, so this was really cool. I had a quick question, thinking back to the results from a few presentations ago on mortality, where they found a interaction between tropical cyclone exposure and heat. And I believe that heat is associated with various adverse birth outcomes as well. So I was wondering, and maybe I just missed this, but I was wondering if you adjusted for temperature in your models, and also if you thought about possibly looking at interactions between tropical cyclone exposure and temperature for preterm birth outcomes.
Yeah, thank you for the great question. And I enjoyed that last talk as well, because when tropical cyclones happen, it do come with like elevated temperature. So that's very relevant, and it's a very interesting study, the interaction effects. So in my model, we choose to adjust it for the temperature because it comes with tropical cyclone, and as you said, it will influence adverse birth outcome as well. So you put that in a model as with 4 degrees of freedom to control for like the general trend of temperature. Yeah.
Got it. Okay, so these were adjusted for temperature. Yeah, it would be interesting also to look at interactions with temperature in the preterm birth context or adverse birth outcome context.
Yeah, definitely.
Very cool. Thank you so much. This was a great talk. Are we gonna do we want to circle back to Elizabeth, or move on? Maybe we'll just move on and circle back to Elizabeth at the end. So next, it looks like we have Zuyu Lin, who's a third-year PhD student at the University of Tokyo. Zuyu, please feel free to take it away.
Hi, everyone. I'll be presenting my PhD project on tropical cyclone and diarrhea disease in multiple Asian countries. Specifically, I'm exploring the heterogeneous effect across countries, across cyclone categories, and outcome data type. Oh, next slide, thank you. So diarrhea disease and tropical cyclone, I believe in the previous talks, it's already been mentioned several times how after a tropical cyclone event, there's tend to be a lot of outbreaks of it, because the strong wind and intense rainfall can really damage the water infrastructure and the sanitation system. And such disruption significantly increase the risk to diarrhea, could increase the risk to diarrhea disease. Well, there are several epidemiological studies on diarrhea disease and tropical cyclone. There are several gaps. For example, there's no comprehensive studies that evaluated wind, rainfall, and combined tropical cyclone metrics in relation to diarrhea disease. And also, most studies are single country studies. There's only one identified multi-country study, and they use a longer-term monthly data, and they only explored wind-based exposure. Also, no studies has looked at mortality data related to diarrhea disease. And among those who looked at morbidity data, there's no study that was able to look at different types of morbidity data, such as surveillance and hospitalization. Next slide, please. And so for my study, I would like to focus on looking at Asia, because so far we've heard multiple presentations. Most of the studies are focused in the US, but Asia is also a very populated continent, and there's a lot of low-lying cyclone-prone coastal zones. And also one of the most tropical cyclone active Western North Pacific basin. As you can see on the figure, the most concentrated red lines are in Asia. Also, there's large disparities in diarrhea disease burden, as you can see on the other figure, with different mortality rates. There's different socioeconomic status and different access to water, sanitation, and hygiene services. So making this region particularly interesting to explore the heterogeneous effect. So for the data, our exposure data from IPTRAC, ICIMP, and AIR5 Land. And for our outcome data, we manage the data from CLIMED, which is a diarrhea disease data set managed by my university, the University of Tokyo. For the study design, we used a two-way fixed effect model. We have fixed effect on year, month, and unit, which is the subnational administrative level, and we explored the interaction of these fixed effects. We use a quasi-Poisson model and adjusted for temperature and precipitation using natural splines, and it's cut off, sorry, but we also considered population. And the figure shows, sorry, I wasn't finished with the previous slide, thank you. So the figure shows the data that we have, and they are color-coded based on what type of data they are. So for morbidity-only data, they're colored in blue, and for mortality and morbidity data, they're colored in red, and for mortality data, they're colored in yellow. And the table next to the figure shows the breakdown of the morbidity data. So we have hospital visits, surveillance data, hospitalization, episode data, outpatient, depending on the availability of the data. Yes, next. As for the tropical cyclone categories, we're really interested to comprehensively look at wind and rain and also the combinations of them. So we have wind-only categories, tropical depression, tropical storm, and typhoon, each with their cutoff values. And then we have rain-only categories, which are percentiles based on the subnational unit percentiles, so that this could account for within country and across country differences. And then lastly, we have a combination of our wind and rain categories. So in total, we have 19 tropical cyclone exposure categories. Next. So here are some preliminary results. The study is still being ongoing. So for figure 2, it's the result for mortality data, and the figure next to it is the result for morbidity data. The x-axis are like the tropical cyclone exposure categories with, I'm sorry, it's really small, with the blue as the wind-only exposure and the red as the rain, and green with different intensities of green shows different pairings of tropical depression and rain, or darker green, tropical storm and rain, and typhoon and rain for the darkest green. And on the y-axis is the risk ratio. And for mortality, we only observed tropical depression in Malaysia that shows like a protective negative association. While for morbidity, there are several significant results in China for tropical storm, wind-only based metrics, and also for Japan, rain-based R99, and also tropical storm and rain 99 combination. Also for the Philippines, in the highest rain threshold, rain 99 and tropical depression and rain 99. And also for Thailand, all of the rain and tropical depression. As well as Taiwan, we see a significant increase in tropical storm. Next slide, please. So thanks to our data with a variety of morbidity data type, we also looked into how these different morbidity data could perhaps show a different pattern. And it's interesting that we see that for South Korea, we have two types of data, hospitalization and episode. Hospitalization, we see more of a significant impact at the higher end of tropical, of typhoon and rain pairs, as compared to episode data. Really, there's not much of a pattern that we see. Similarly for Thailand, we have hospitalization and outpatient data, and there are more significant patterns seen in the hospitalization data. And lastly, for Taiwan, we have three types of data: hospitalization, outpatient, and surveillance. And for surveillance data, it was most interesting to see how at typhoon, we see a significant increase in risk, and also the pairings with rain. So that's all for my presentation. Thank you very much.
Thank you so much. This is fascinating. Really cool to see work from Asia. A question that I was thinking about as you were presenting is sort of why the results look quite different across country. Maybe some of the mechanisms that might lead to those differences. I wondered if you had any thoughts about that, specifically if differences in water-related infrastructure across countries might account for some of the differences and effects.
Yes, definitely the motivation to do multiple countries is to really see what are the drivers, and it's most sort of the first thing that I thought of was socioeconomic status and probably wash end that would impact, but it's not as easy to see that as with the limitation of the data, because we cannot get the same type of data from all the countries that we wanted to see to explore. It's not a fair comparison. And from what we've seen, what I assumed in the beginning of lower socioeconomic countries probably having higher risk, we didn't see that actually. And the explanation of it could be because of the different type of data that we're looking at. And that's that's something think about.
Yeah, super interesting. Thank you so much. Our next presenter is going to be Michelle Evans. Here are your I can see your slides. So please feel free to unmute yourself and take it away.
Thank you. Everyone can hear me? Yes, great.
Yes.
Perfect. Well, thank you for the introduction. She said, I'm Michelle Evans. I'm a research scientist at Pivot, which is a health system strengthening organization that's based in Madagascar. And today I'm going to talk about some of our work surrounding health system strengthening and cyclones. So, perfect. So this project focuses on one cyclone as a case study, and this was Cyclone Batsirai. It hit Madagascar in February 2022. And as you can see on this map on the left, it went directly through the country. It also went directly through the middle of the health district where the NGO I work for works. It's called Ifanadine, and you can see it outlined in black. Next slide. So this is one of the worst cyclones I've had in the past couple of decades. This is just some photos from the district. You can see it destroyed the road and health system infrastructure, people's homes, and there was some major flooding events as well. Next slide, please. And like I mentioned, this district is also the site of an ongoing health system strengthening intervention. So this is a program that's done in partnership with the Ministry of Health of Madagascar and the NGO Pivot. And the goal is to strengthen the health system to achieve universal health coverage. So it started in 2014, and you can see here on this map, the communes that are in kind of pink are those that have been benefiting from the health system strengthening intervention since then. And those in blue started around 2019. And as of now, and as of the time of Cyclone Batsirai, the intervention covered all of the district. Next slide, please. So for those of you less familiar with health system strengthening interventions, this is based on the WHO building blocks. There's 6 main building blocks, and it implements them kind of using a vertical program, so community, primary, and tertiary care levels. It also combines this kind of more formal programmatic support with a suite of values and norms that are really specific to the intervention itself. And these are ones that prioritize rapid local adaptation, the use of data and decision-making, the use of communication across different levels of the health system. And I also just want to note that this isn't necessarily an intervention that targets climate change or targets adaptation to cyclones. It's really trying to broaden, it's really trying to strengthen the health system at like a broader level. Next slide, please. So given this overlap of Cyclone Batsirai and the ongoing health system intervention, we thought it really provided an ideal case study to understand if and how an intervention such as this could serve as climate change adaptation. Next slide, thank you. So we used a mixed method study to answer this question. It included quantitative analyses of indicators of health system functioning, as well as some qualitative analysis of interviews and some archival documents from that time period. And this allowed us to explore the role the health system played in both the preparations, the immediate response, and over the long term. And I've just included kind of an example of what these results are going to look like, just to help orient folks as I try and move very quickly through this lightning talk. So there's going to be some time series of indicators before the arrival of the cyclone, this dashed line that represents when Batsirai arrived, and then the indicators for the period afterwards. And the colors correspond to what I showed on the map earlier, where we have the area that's benefited from the health system strengthening initiative for a longer time period versus more recently. Next slide, please. So in the period just before the cyclone, during this kind of preparations period, mostly what was focused on was strengthening the supply chain. So this included the creation of an external emergency stock of medicines, the preparation of emergency food kits, and then also the deployment of some staff, some health system staff to more isolated regions to help encourage people to move to temporary shelters. And overall, what we saw was that this was a success. So there wasn't much disruption of the availability of what we call tracker medicines. So this is kind of the most common medicines provided by the health clinics. And we also found that because so much of the population living in these more low-lying, flood-prone areas were moved to temporary shelters, there's actually 0 deaths that were directly attributed to the cyclone. Next slide, please. So immediately after the cyclone arrived, there was the deployment of mobile clinics by the health system. And a lot of these went to where some of those temporary shelters were. And the thing that's unique to this intervention is it wasn't just the deployment of clinics, but it was the deployment of the whole system of data collection and analysis that already existed in the district that went with them. And so this allowed the health actors at the district headquarters to really follow any potential outbreaks of disease and get constant data about what was going on. And it also meant that patients could continue to receive care without having to travel to the clinics. And we saw that this did really limit infectious disease outbreaks. This is just one example looking at malaria case rates and positivity rates. And we found that there was no significant difference. The second kind of immediate impact was on the transport network. If you remember some of those photos, there was whole roads that were washed out. And so a relay ambulance system was established, as well as a food for work program, which kind of provided food to the community to restore some of these transport networks. And we saw that once that was put in place, it did work really well. So this is a plot of the referral rates to the hospital. And we found no change in hospital referral rates. So patients were still able to get to the hospital to receive tertiary care. Next, thank you. And finally, we have the long-term impact of the cyclone. So vaccination programs were initially disrupted for kind of 2 reasons. Clinics and practitioners had to focus on treatment rather than providing preventative care. And there was also a lot of loss of vaccine stock due to the loss of cold chain because the electricity was interrupted by the loss of solar panels. But this did recover after several months and has continued to kind of improve over time. Similarly, we saw that because this is an ongoing health system strengthening intervention, we're kind of in the process of increasing access to care. And we didn't find that this major cyclone event necessarily disrupted that. We're still seeing this kind of asymptotic curve that we would expect with the intervention. But one domain that still is really negatively impacted is malnutrition. So the cyclone in some regions destroyed over 90% of rice fields. This is kind of the primary food staple in the region. And so that increased people's food security as well as destroyed their source of livelihood. So we saw almost 100% increase in malnutrition cases, and this continues to this day. Next slide, please. So some conclusions that we can draw from this. In general, once there was this kind of external input to help restore infrastructure connectivity, especially the road networks, the health system was able to continue functioning as normal. Our interviews revealed that it wasn't just the fact that there was these support for those 6 WHO building blocks, but that it was also due to this system of communication and relationships that already existed between community members, health actors, and other stakeholders. So especially for getting those roads cleared and open again, that involved people from the military, the health system, the transportation system really working together. And finally, like I mentioned just at the beginning, the intervention is adapted for the local context, but isn't necessarily a climate change adaptation. It's not designed in that way, but it is designed to help deal with what we kind of call everyday shocks, which are just these regular disruptions that you see to the health system, particularly in low resource settings. And we found that that served kind of in a similar way during this more extreme shocks, so that by making the system more resilient to these everyday shocks, it can also protect the health system against these cyclones. Next slide. I think it's just a thank you slide. Yep. So thank you for your time. Thank you for listening. Thank you to the organizers. And I don't know how much time I have left, if I have time for a question or not.
Maybe just one quick, this was really cool to see the more on the ground perspective and a different region of the world than we've seen in other talks. I was curious, as you were talking about malnutrition impacts, that's not something that we think about as an impact of tropical storms too much in high income countries. So I hadn't thought a lot about that, but I was wondering if you know of any sort of actionable steps or interventions that could work for mitigating impacts of tropical storms on malnutrition in low and middle income countries.
Yeah. So I can speak a little bit about what we did specifically. So there was kind of in the immediate response, there was the distribution of food kits. So that involved giving out rice, oil, salt, I think like some beans and protein as well, especially to people that had moved to that temporary shelter. But a lot of this has to do more with just the fact that households are not very economically resilient in the first place. And so all it really takes is this kind of one shock to put them in a place where it becomes much harder to recover. And so from a health systems perspective, we've started a program that focuses not just on severe malnutrition, but moderate malnutrition, which isn't done quite as often. And so we're trying to get cases before they become these severe cases that have a lot of like associated morbidity and mortality. But a lot of what needs to be done is kind of increasing that economic resilience, which is involved with health, but isn't necessarily in the like exactly the objective of the health system in general. So.
Makes sense. Thank you so much. This was a really cool talk. We're going to move on now to our next speaker, Elena Naumova. Please feel free to unmute yourself and take it away.
Can you hear me?
Yes.
Yep. Very good. Thank you very much. I would love to talk about Hurricane Katrina, and it's a part of the structure we are using for modeling different events which have really very specific nature. They comes and go, and we call it the intermediate or interruptive type of effects, which have really very complex features for modeling. Next slides. And next one. So I put them in 3 specific buckets, all these challenges for spatial temporal modeling. The first one, which I see as a challenges of temporal interdependencies. We have delays. We already hear about lag effect. We have leads effect, which have really very important forecasting property. There are also periodicity oscillations and seasonality, which make that amplification really very challenging to disentangle. We also see potential for synchronization and also for compound and cascading effect. This data sort of like shifted in terms of time, and you constantly need to find the proper alignment in a temporal and in a spatial structure, which have which have another type of challenges, and I would put them spatial heterogeneity challenges. We can understand those challenges through distances and proximity, because of sometimes the same distance and the same proximity produce different type of events. There are distortion and interruptions in our understanding how we can assess land use or land structure or urban versus rural divide, because if it's not so smooth and not so clear in this type of a division. And probably the most important one, that's a curse of 3P. It's a place of residence, place of exposure, and place of hospitalizations. And these three locations are very rarely well aligned. And the last one, the last bucket, I believe the probably most challenging, it's challenges of spatial mismatch and spatial realignment. We have challenges of realigning data with respect to time, to space, and rate of change and rate of speed. And that's a fantastic example to study hurricanes, to see all of these challenges at once. Next slide. So I want to give a little bit more clarity what we are dealing with when it's come to space-time reference data for modeling, especially when it's come to specific events like hurricanes. These data need to be organized in chronological order according to their geographical locations. And we have needs to connect together data which are analog-based, like temperature and the wind speed, and this data will be collected pretty regularly. At least we know what is the regularity of collecting this data. They come typically in a much higher frequency than the data related to mortality, morbidity, and everything related to counts. And we need to convert those record-based information into usable time series. So this is by itself is really very important challenge, and leads to selection of proper distribution, proper adjustment, and proper alignment as well. And the curse of 3P, place of residence, place of exposure, and place of hospitalization are very rarely aligned in our ability to assess it, and where they occur in reality, and what data will allow us to detect as well. So how we can manage this type of challenges at once, and it might be not really the easy task, but I believe we need to be very much aware about these challenges. Next slide. So I want to give you a couple of examples how we can deal with trucks and how we can align analog data and convert this data in something usable at the level of zip code, place of residence. This is how the health data are connected. Please click once. And when you click next time, please click one more. You will be able to see the buffer. So according to that forecasting idea, it's basically a buffer zone for the trajectories related to hurricane track. And please click one more time. This would be a conversion of this data into sort of probability of being exposed to different challenges related to hurricane using the county level data. And that concept we will use for this analysis as well. So next slide. What we decided to do, we extracted data from Medicare and Medicaid services database. We plow through 300 million records collected over almost 10 days of these data collections, and we narrowed down the most complete data set of cardiovascular diseases during Katrina. We follow very carefully Katrina tracks. We watched very carefully which data we will be able to use for this type of analysis. We decided to focus specifically on Louisiana, on 3 parishes. We know which parishes were affected the most, slightly least, and where people will be moving from one parish to another. And this sort of like behind the scenes, what you need to know about this alignment of place of residence and place of exposure and place of hospitalizations. And of course, we need to consider where people live, what is the population density, and how this population density can be reflected in the modeling later on. But most important in this regard, it was not only think about spatial locations, but the temporal intervals or temporal elements related to this data as well. Next slide. So we decided that the most important for us to work with this data is truly to understand the time intervals before Katrina and after Katrina. And it's not enough just to say before and after. During the announcement evacuation, which would be represented by this darker yellow strip, you can see decline in cases related to hospitalizations. It means there is a less capacity in this whole entire region to deal with any problems, or people are not really calling for any events. But within a really very short interval, and this is reflected by landfall, it's 1 day following landfall, we see a sharp peak in increase of cases, which will follow by a decline. And those declines done in 2 weeks interval and next consecutive 2 weeks interval. And we decided to check more carefully how well the level before Katrina mimic the level after Katrina overall. So we took 6 distinct time periods, 3 specific geographic locations, and 2 major subpopulations. White adults and Black adults primarily residing in these populations as well for this specific type of a comparison. So next slide. When we assemble all the data together with these 3 locations, we were able to see that all 3 have somewhat similar structure in responses, but not truly identical. The parishes which is most affected by flood have the highest spike in cases of CVDs. The community which was also quite strongly affected, but have much less extent of the flood, also have a slightly less extent in the peak. And we also see a community where a lot of people were migrating and moving in. And actually, it's a reduction of the cases of CVD in these specific locations. What was important for us also to establish a much better link between different tools and techniques we use at an analytical level. We apply smoothers of different kind with different type of distributions, including negative binomial, zero inflated negative binomial, Poisson, and so on. But we end up working with a segmented linear regression models with interrupted time series. But interruptions are not really implicitly done. It's done through the proper stitching of exact intervals. And using this type of techniques, we have a high level of interpretation of the results related to this specific event. Finally, the next slide, you can see, one more click, please. You can see the drastic difference between African-American adult, it's actually elderly population, 65 and higher, and a white population. And even if there are practically no differences before and since after in this specific, in daily hospitalization, but on the day of event, the spike was almost 2 times higher for African-American population compared to white population. This would be only possible to see if we have this level of granularity of data. So I fully advocate for whenever we will be able to protect daily measurements, is probably the most important one to see if we want to capture this level of granularities as well. And in my recap, I want to strengthen in that preparation of time series from administrative data set require attention to important details. When you organize this data as a time series, we need to have much higher level of granularity to allow us to reveal critical patterns in this data and watch very carefully for different intervals which change very rapidly. And those intervals could be masked in broad weekly and monthly records. And analytical tools need to be explored in a much wider range of different techniques in order to capture nonlinear spikes and slow declines before and after the hurricanes. And I'm very thankful to my team at CORT program back at Tufts University and open for any questions.
Thank you so much, Elena. Wonderful talk. I really enjoyed the methodological flair as a biostatistician. It was nice to hear a little bit more about the methods side today. I do think that we're running really tight on time, so I think we're going to skip over questions for this talk, but folks feel free to reach out to Elena on the chat if you want to ask her questions while we hear from our next presenter, who is Ryan Zomorodi. Ryan, please take it away whenever you're ready.
Sure. So hi all, my name is Ryan Zomorodi. I'm a research analyst at the Children's Environmental Health Initiative, and today I'm here to talk to you guys about why localized multidimensional aspects of severe weather exposure matter for vulnerable populations, particularly older ones. So next slide. So as the previous speakers have talked about, severe weather exposures place vulnerable older adults at increased risk for mortality due to the greater reliance on healthcare services and lower resilience of those healthcare services after severe weather exposure. But the process of getting to kind of that conclusion requires us to estimate exposures. And we've talked a lot about today different ways of estimating those exposures, and we're going to talk right now about some of the exposure measures we at CHI have been working on. So this will kind of be a little bit of a preview of, I guess, Dr. Brooke Anderson's talk later, so it will kind of be a little bit of overlap. But so we know that this exposure estimation is necessary to understand those key drivers of hurricane-related mortality risk. And one thing we also want to talk about is the fact that these hurricane exposures are not simply just wind, they're not simply just flood or precipitation. They're multifaceted, they're complex, and ideally, we would like to assess them at highly resolved spatial units. Next slide. So I'm going to introduce 6 different hurricane exposures. They kind of fall into 2 broader designations. They're either intensity or duration. And the first couple, first 3 at the top here are all from Dr. Brooke Anderson's storm wind model package, and that's closest distance to storm track, maximum sustained wind speed, and duration of wind speed greater than 34 knots. And those are usually the typical ones that we see within the literature. So we wanted to kind of expand on that and also include cumulative precipitation and percent of population that lost electricity during or after the hurricane, and the average number of hours in which electricity was lost per customer. Next slide. So this first one, we took NOAA HRRR 2 data and we plugged it into the storm wind model, and that allows us to get a whole host of different measures. So we can see the minimum storm distance or minimum distance to the storm for each individual tract, and then same for the duration of the sustained wind speed above 34 knots and sustained wind speed, the maximum one in knots as well. And what we can see is that when we look at all these together, they do capture different aspects of the storm. So while they're obviously highly correlated, we can see this is Hurricane Matthew. The lower part of South Carolina seems to be hit by the highest maximum sustained wind speed, while it seems like the coastal Georgia area had the actually highest duration of wind speed above 34 knots. So using different metrics can kind of help us get at different things within our idea of exposure. Next slide. And then we also took track level, we calculated out track level precipitation. And so the hurricane exposure data package actually only limits the data to about 2018. So we took NOAA NCLIM grid data, and we calculated aerial weighted mean for every single day within a hurricane's duration. And that allowed us to sum it all up and get total precipitation at the track level. And as compared to the previous exposure measures, we're now also capturing a different aspect of the hurricane exposure. Next slide. And then lastly, this is something we don't often see within the literature, but we wanted to look at outages because we know access to electricity is a common concern after hurricanes, and can be particularly concerning to individuals, especially older individuals who rely on appliances that for their health. So we calculated out maximum outage percentage and maximum outage duration, or I'm sorry, mean outage duration per customer. And what that ends up looking at like is for each county, we have kind of a time series of the outage, and we can take that max point and also the area under the curve, and that gives us our maximum, and then the mean outage that the average customer would expect to endure after the storm. And then next. And we can see altogether, all these different measures cover different aspects of hurricane exposure. So later on, we plan to model out several different storms, so 15 major storms, and utilize each one of these as exposure measures. And then last one. So in total, accessing exposure at these highly resolved spatial units allows us to better capture the spatial variability and risk, and improve the accuracy of our exposure estimates, and better identify vulnerable populations affected by severe weather. In the future, we plan to develop a composite local level measure of exposure and incorporate different timing concerns within our exposures. And then last slide. So thank you to my collaborators at both at UIC and University of Michigan. And if you're interested in looking at some of our exposure measures, you can check out the GitHub repo where we have all our calculations there as well. Thank you.
Thank you so much, Ryan. Really cool and important work assessing exposure to these storms. We will, I think, skip questions again. Sorry, we're running really tight on time. Actually,